Hello, friends. Thanks for tuning in again to The Doctor Is In, but actually it's The Doctors Are In today because Dr. Judy Norman is with me again. We had such a blast last time. We decided to make a regular go of it. Now, I don't know if it's going to happen every month or every few months, but she's going to be with me on a regular basis now to discuss the issues together about what's happening at the intersection of health and human trafficking, and it's great. So today we're focusing our attention on healthcare providers, doctors, nurses, other even administrators, people working in reception, anyone who's working at this intersection of health. And we're going to talk about how not to be a jerk. So basically, trauma-informed care for doctors. And, because there's a lot of things that, we do that can be harmful, even in the course of doing our regular duties. And it's entirely unintentional. But we're going to give some examples. We're going to talk about this space. We're going to talk about, what does it look like as a physician or a nurse or someone who's setting up a clinic, either directly for people who are sexually broken, or people in prostitution, or survivors of sex trafficking, or how we can work in some of these principles into your regular practice. And so thank you for joining. I'm so glad. Please subscribe to the podcast on Podbean or wherever you get your podcast, or to my YouTube channel. I really appreciate it. So we'll get going, and hope you enjoy this approach to not re-traumatize people. We do that unintentionally, unfortunately, and so we're going to get to a whole bunch of things. So just to introduce Judy again, Judy's, why don't you introduce yourself?
Hi, I'm Judy Norman. I'm an OB-GYN physician from the States. I've been in Cambodia for almost 9 years. I unintentionally developed an interest in engaging in anti-trafficking here just through patient care and through working with other NGOs here. So we have a women's healthcare program out of our hospital. My main focus there is teaching our Cambodian doctors and nurses and healthcare workers. But we as a team work with NGOs who are on both the prevention and the post-rescue and the reintegration and the job training aspects of we also work with some street workers, some drop-in centers, and things like that. We kind of have a big picture of potential farm workers and active street workers and everybody in between. So had some in-person real-life experience beyond what we've read and what we've discussed.
Yeah. So between you and I, we have quite a lot of experience, a lot of learning, and sometimes learning the hard way, I think. And so we're not saying we're experts, but as a good friend of mine likes to say, that we are lead learners, and that we want to take this opportunity to share some of our experience and some of our knowledge with you, and how you can develop your practice or your hospital or the way you're dealing with patients in the everyday to help you do what you do better, because that's our goal, is to make this I'm losing my cord here. To make this just a better world for the people that we serve, because it's important. And the focus here is on human trafficking, slavery, exploitation, but a lot of what we're going to say here really applies to anyone who's experienced chronic trauma, and who may be sensitive and may need some extra help, or exhibit signs and symptoms that may not lead to a history of being trafficked, but definitely chronic abuse, domestic violence, things like that. But our focus is mostly, and examples is mostly about human trafficking or sexual exploitation, such as prostitution. So we're going to offer some anecdotes, some papers, some all kinds of things here. And so, one of the things that how I got started in doing this is because I was seeing, I was working with organizations and I was working with doctors, and they'd say they'd ask me, so, hey, Dr. Catherine, could you come and help see some of our women? and because they don't want to see the doctor, but but I think they'd see you. And I said, what? They don't want to see the doctor? Why don't, and this is an organization reaching out to prostitutes in Bangkok. And, they were like, well, why don't they want to see the doctor? I mean, what's wrong with us? Like, why wouldn't they? Like, I'm an American and my Thai is good, but, I'm not fluent. And what could I have to offer that the Thai doctors don't have? And this is sort of a naive way of looking at it. And, a lot of the doctors were like, yeah, I mean, what's wrong with the way that we do things? And some of the questions I get is like, well, if it was so terrible, why don't they ask for help? Or, right? Or if they want help, why do they lie so much? Right? This is another question that I'll hear from some of my colleagues. And, these kinds of questions put blame on the victim as well. But, I wanted to explore, well, what is it about the way that they're practicing that makes it not so pleasant experience? So I don't know if you have anything to add or similar experiences there.
Yeah, we all know the phrase "first do no harm."
Yeah.
And we go through our medical training, wherever it is, we're taught a very specific set of what that means. And, we ask open-ended questions and we take a good history and we find out about the patient's background, and we're trying to get questions so our history is complete, and we're doing a full physical exam. And all of that first do no harm, we think, is approaching how we treat with medicine or how we do surgery or not. But first do no harm may actually involve the first words out of our mouth or the questions we ask. And for victimized or trafficked people, oftentimes sharing the story again re-traumatizes them. They're going through the emotions and the feelings, and it's a PTSD reaction, and it's significant and it's and what we've found, we work with multiple different NGOs, especially the younger the victim or the more prolonged time that they were in a trafficking situation, the harder it is for younger people to even recognize what was done to them or to be able to tell a history. 12-year-old shouldn't have to tell you, yes, she's had sex. How many people have she had sex with in the last year? Those are the questions we ask for assessment of risk for gonorrhea and chlamydia. That's the CDC question. Asking a 12-year-old girl who's been trafficked, how many people have she had sex with in the past 3 to 6 months is harmful. So when we have what we call referring partners, that are individuals or people that bring patients to our clinic, and we have certain NGOs that we work with, and when they bring in a group of girls, we automatically give all of those girls presumptive treatment for gonorrhea and chlamydia. We don't ask about sex. We offer them education about women's health care. We talk to them about normal bodily functions. We present the information about sexually transmitted disease. And so we're giving education that they can choose to receive. And then when they get one-on-one with the doctor, we just simply say, is there anything I can do for you? Do you want me to do a physical exam? Is it okay if we draw blood? And if they don't want anything done in terms of a physical exam, we can still do presumptive treatment. If they will give you a little bit of history, but don't want a physical exam, and they say, well, I've just got some itching and burning, we can do syndromic treatment based on what they tell you. If they want to do a physical exam, but they don't want to tell you why, you can. So we've learned that when we are more aware of where they've come from, either through the partner that brings them or through the situation that comes to us, our questions should stop. And really, we need to be available without being as invasive as a normal, healthy healthcare relationship would seem to be.
Exactly.
And that's hard, and it's retraining.
Yep.
There's a lot of thinking very carefully before you speak.
Yep.
Is this question necessary?
Yep.
Is it harmful? Will the answer change my management or
Yes.
not?
Yeah.
And if the question is coming from curiosity in any way, shape, or form,
Yep.
it should be asked.
Exactly. Yeah.
Yeah.
Yeah. Yeah. Because, we can unintentionally, because in the course of doing exams, it's like, okay, come in. And there was a story about even someone in Cambodia going to and the doctor was assuming like, yes, patient autonomy is very important because, he's learned his good ethics course in medical school or in practice, and autonomy is important. And so he refused to allow the chaperone. This was someone who was in aftercare assistance, and the chaperone was a case manager or social worker from the organization. And he said, well, actually, we don't allow someone else. And of course, the patient wanted her in. The chaperone kind of said, well, actually, I don't think this is a good idea. And then the doctor proceeded to then re-traumatize her and set her back in therapy. And, and it's just because this person the doctor, should not have done that. I mean, was thinking he was doing the right thing when actually it was, just not thing, just like you said, because this was not a situation like where we've been in, where we know when certain patients are coming before us, we know it's this organization, we're doing a clinic for them, or they're bringing a patient to us. And we know that because this patient is affiliated with this organization, we already know enough about her history in order to be more aware of what's going on. But there's going to be times when physicians or nurses or clinics are not going to be aware. Right. But we're not going to go down the rabbit hole of identification here. But there's still principles that we can apply. We can unintentionally apply, re-traumatize patients by making assumptions or dismissing them based on dress or behavior. If someone looks like, because they're like, they come in dressed a certain way or not a certain way. And so they're making assumptions, or or you think, patient who's acting belligerent, right? Or having this tough girl or this tough boy and putting on a show and putting all kinds of barriers, right? And, that's going to be a patient you probably need to pay more attention to, even at the same time where they're refusing and resisting trust and resisting that doctor-patient relationship and not wanting to be vulnerable or tell the truth or something, because they're, one, afraid, or two, just don't like you, and they're there because they really have a problem that they need to have taken care of, but don't really want to be there.
And they're often the case where they're either made to go by another organization, or they're trying to meet a very specific need, but do not want to discuss why that need came about. And it can be very challenging, and it can be, so sometimes it's, can you tell me what brought you here? I just have this pain. I just need some medicine to fix it. Okay. Do you have any idea where this pain came from? Doesn't matter.
Yeah.
And if a patient's shutting you down and they have a reason for it, the next question is, are you safe? Is there anything I can do to help you be safe? Sometimes patients will refuse an offer of safety. And again, that's where we have to be aware, physicians, are they in a position that they can't ask for help, or do they not want help? And there's a lot of intuition and a lot of awareness. I will walk out of the room if a patient's waiting to get a lab drawn, or they have to wait for payment or whatever, their medications. I might wander out and walk past and just observe from a distance. Are they sitting with somebody else? Are they showing signs of agitation? Do they look comfortable? Is there anybody near them? Do they have a phone? What is their level of autonomy? Or you might ask some support staff or another person who hasn't identified you in the room to go out and make an observation. Yeah. Have some questions about that patient. Can you just walk out there and see what's going on?
Exactly.
Tell me if you see anything unusual. And we're not breaking confidence to say, put your eye on that person for me. Give me some more insight.
Yeah. Because there's going to be a lot more that you're not seeing when they're in the exam room.
Yeah.
who is or who is not there, and who's outside waiting for them, and how do they seem. That's all part of the whole Gestalt picture. And I just want to reiterate something that you said, was that it's accepting no, as an answer, and having that be a part of their dignity of refusal, because a lot of times in their life they're not able to say no to the things that they don't want to have done. And of course, as a physician, we wouldn't recommend something we didn't think was good for them, but also understanding that their no means no, especially to a physical exam, and especially a gynecological exam, but also other kinds of blood draws. But making sure that they understand what no means. Because when they may not even say, "Well, can you do a physical exam?" and you're like, and they say yes, and they're like, and then you start to do a very invasive physical exam, and so we have to be a lot more concrete and take more time to explain things. And what do we mean when we say doing blood work or lab work? Because they may think that needle's going to be several centimeters long and take a half a liter of blood or something, and making sure your instructions are a lot more concrete. And taking more time with the patient. That's another thing that I've heard over and over again. And explain things. What are you going to do? Why do you need to do this? And what's going to happen? And explaining things step by step.
Things you don't need to do,
Exactly.
Right? A 24-year-old woman, unless she has a specific complaint, doesn't need a breast exam.
Exactly.
Why would you? Don't do it. Don't do unnecessary parts of an exam, again, to check a box on a form and up your coding for your billing or anything. Only do what's necessary to meet patients. And we
and that's taking individual, and that's individual care, and doctors need to consider, why are they doing the things that they're doing during a physical exam or history taking? Why are they asking this question? Like you said, that's, of course, that's rule number one. Don't ask out of curiosity. And
I always start with the easy part of the physical exam. Can I listen to your lungs? Can I listen to your heart? Can I look in your eyes? Is it okay if I look in your ears? And then, you want to let the patient be dressed. The patient should be in their clothing when you first talk to them. Never send somebody else in and get undressed, put them in a paper gown and have them sitting on a table with their legs in stretch when you walk in the room. That's me. I wouldn't let anybody do that to me. No. That's not going to happen. You look me in the eye and you talk to me as a person.
Right.
Then we'll go from there. And if I don't like you, we're not going to go. So you should be talking to the individual person as a person of worth and in the community. Have a conversation with them, give them some education, offer them some care, and then base on what they accept or don't accept. And I've had a lot of patients who want a physical exam, but again, if they've been traumatized and they're afraid, if they do not want a full GYN exam, I can say, well, if you can handle it, I have a swab, and you use a little tiny Q-tip that has a long stick, and you can say, if I can do this for you, or the nurse can, or you can do it yourself, if you can put this inside, and then I can put this on the microscope, and I don't have to actually look inside myself. We can also do HPV tests that way. You can do self-swab for HPV. So there are a lot of things you can do without an invasive GYN exam.
Yeah.
You can do urine tests, and part of it's on the patient. I mostly of the time just do microscopy, but I can look at myself right there. Some people have NAT testing for gonorrhea and chlamydia. Some people have all sorts of fancy tests, but you can do very basic evaluation without necessarily doing a full physical exam. And again, as you build that trust, maybe later that day or another visit, they might be comfortable enough to allow you to do more if they need it. And if they don't need it, then
right.
And that's been the biggest part of our learning. And when we give education, it's sometimes, and this seems counterintuitive, we found, especially for young women and girls who are scared, group education and group visits can make them feel safer.
Hey, I'm gonna hold on, Judy. Your audio is getting worse and worse.
Okay.
So I just want to make sure, like it's gonna be a little hard for people to pick that up. So,
let me see if I can switch my. I will put my hotspot on. because our Wi-Fi has been bad. So let me try this.
I mean, it wasn't quite breaking out, but it was getting quite faint.
Okay. Let's try. Tell me if this is better for you.
Yeah, so
You
far
hear
I
me
think
well
we just go. Yeah, sorry to interrupt. I hope you can remember where you left off, but you were getting to a good point. We could barely hear you. So
What was that good point I was
no, you were talking about. Yeah, what was it? No, you were talking about just informed consent and going through, and then
yeah. And one step at a time. And again, letting technology be your friend. If your patient can't handle an exam, do
Exactly.
blood work. And you can ask them, is it okay if I look in your blood for HIV, for hepatitis, for syphilis? I'd like to draw blood to check for anemia. We check a urine test. We can look for infections. We can look for pregnancy. We can look for things. Is all of that okay?
Yeah.
And the patient decide yes or no. And when we've approached it that way, we've had patients who we've never heard anybody say no to the blood work in the lab. And then again, depending on the patient's age and what they've been through, they may or may not like a partial or physical exam.
Yep.
But we can adjust care accordingly. But I was saying to the group visits, and again, counter to my culture where we're very individualistic and private. And this would be culturally dependent and situationally dependent. We have found here that a group visit makes the women feel safer because nobody's in it alone. Nobody's the only woman getting a GYN exam.
Yep.
Nobody's the only person who's getting checked for trichomonas. So we have a group visit where we give very factual education and information at the beginning. This is what we're doing. This is why. Ask questions. And when you open up questions to the group, if one person asks a hard question, all the barriers come down and then everybody else can ask the questions and they can learn from one another as well.
I found that also to be true. Yeah.
Yeah. We've really found that the group visits inspire confidence from women to each other. Really, it's not so much coming from us as it is from the women sharing. They have a shared experience. They don't have to talk about what the shared experience is, but they know they're not alone.
Yep.
And that gives a sense of safety. And then they're not as afraid to do parts of the exam that may otherwise scare them because they're not doing it alone.
Yeah. And another thing that I thought of is that because the education of these girls or even boys may not be so much, especially in Southeast Asia, when education about sex and anatomy and physiology is really taboo and no one explains it. And yet here they are as young people being sexually exploited and expected to do things they don't even understand or the ramifications of it. And so it's another reason to be more concrete and more explaining about what's going on and why and how they can protect themselves also, or what health is and what's normal and abnormal. So that's also even when I'm teaching other the staff of the organizations that are helping the non-medical staff of some of these organizations, because they don't know and yet they're faced with having to deal with these things. But that'll go a long way. You're not just explaining for no reason. It's not because they're stupid. It's just because it's really because they don't know and have never been taught properly what is normal menstrual cycle, or what is normal for what even are the organs and how do they fit in your body oftentimes. And so that's yet another reason to be explaining. And even, when I'm explaining HIV, they'll say, no, I don't want an HIV test because I'm afraid of needles. Well, they think the needle's like huge. It's like, I'll show them this little finger prick needle. I'm like, oh, is that all it is? Oh, okay. Oh yeah. Okay. Well, and they're like, oh, I'm totally cool with that. Cause I thought you were just going to take a whole bunch of blood. But once you explain what the test is and how it works and how long it takes, cause sometimes if I'm doing a clinic in the milieu and they're like, oh no, I gotta get back to work. I'm like, this is just 5 minutes. And I'm like, oh, okay. Yeah.
And even the words that we use, like sex or HIV versus AIDS and things like that. So a 12-year-old girl, if you say, have you had sex? She's going to say no, because she hasn't. She was raped.
Right.
She never chose to have sex. She didn't have a boyfriend. She's not going to say yeah, because she didn't. And so we have the young men who are maybe heterosexual males and who have a girlfriend. If you have, yes, I have a girlfriend. I have sex with my girlfriend, but on the street, they may be male prostitutes. That's the only way they can get funds. Right. So asking somebody, are you heterosexual or homosexual, does not actually identify with that. We just need to be very specific, very simple, and very straightforward with our questions. Again, if it's indicated in order to give medical care. And sometimes we don't need to ask those questions, and they can come back to us later if it's not the right time to ask those questions.
Right.
And so much depends on how are they coming to you straight up? Is it somebody who's coming to you through a rescue organization who's had 3 months of counseling? Is this somebody who's going to get a final health checkup before they're getting reintegrated? And so where the somebody is on their trafficking spectrum, it's a big difference in how we can approach a conversation. But you had said something about words and education. And in Cambodia, they say AIDS. They don't have the word for HIV differentiate. And of course, if you think AIDS, you think death.
Right.
And so we have to spend a lot of time actually educating our staff and then our patients and the community. HIV is a people virus. And there's actually really good medications, and the quality of care on that here is very good to where we have people with 0 viral loads who are living well into normal adult life. So say testing for HIV and they use the word AIDS, and the patient is afraid because they're afraid of the connotation of dying and death. It's really important to, before we even talk about doing the test, part of our education is the virus, which is HIV, which may or may not cause AIDS, but actually right now there's really good medicine. This is how we So if we test for this, this is why we test for it, because this is something we can treat and prevent and actually take really good care of you. So don't be afraid.
Yeah.
But we have to preface asking to do an HIV test with education about the treatment of HIV, because HIV is, and the treatment is really good. And that has changed. That's something that was different 20 or 30 years ago. And it's really important for everybody to know their individual context. What's going on in your local community?
That's right.
What are the healthcare risks in your local community? So if somebody comes in with blisters on their genitalia in your local community, is that more likely to be herpes or chancroid or chancre? Or you should know in your community, because they may not be able to afford the test that would be required to differentiate, and they might not want you to even look.
Yep.
But you can ask basic questions and be educated yourself about what is going on in your community, so you know how to do less in-depth healthcare, but still do it very well.
That's right. And yeah, I mean, we got to train our whole, it's not just about the doctor or the nurse being trauma informed or, informed about these issues. You've got to train your staff that are doing the voluntary counseling and testing. You've got to train your receptionist and things like that. And so I want to get into sort of, we've sort of established like in the clinic setting or in the exam room kind of thing, but what have you done to set your environment to make it more of a safe space so that, even before they come into your exam room, what are some ways that we can make that environment feel safe so they're still relaxed when they actually come see you in the exam room?
Right. Well, we've been really privileged. We had donors, and we have a separate women's healthcare clinic. So we've got, our primary care place is very busy, people coming and going. There are men and women, boys and girls, adults and kids, and there's a lot of activity, and they tend to do a lot of discussion outside. So the nurses will do the triaging. We've got a triage area there, 2 or 3 people there, they're asking the why are you here question, and doing their blood pressure and their height and their weight out in that precepting area that's semi-open to the public. And that is okay in this culture. In this culture, that's not offensive in a general clinic, but it's certainly not okay for a trauma clinic. We have a cares area that's a separate area where we can do everything in one place except the main hospital, where we can bring one person or 10 people, and it's safe, it's separate. Women's health only. We have only our team who are our trained staff who are there, and they only talk in the room with the patient one-on-one. So all the histories and the vital signs are done there. The labs are done there. The patient doesn't have to go back and forth to the different locations. We try to. And again, that is we were having the funding for that, and that is a not easy thing to achieve. I understand. You can't always have a perfect facility
Right.
with a separate space, but even they walk up straight to the exam room and do your intake history and do your vital signs in the room with the door closed rather than out there.
Yeah.
Those little things matter.
Exactly. And it's establishing safety or a safe location. You happen to be in a clinic, but then you have a women's clinic, which is sort of, you're not going to have, that's not access. So you're not going to have a whole bunch of men in the waiting room yeah. And so you do what you can with the things that you have, and trying to maximize those points.
And again, even in if you have one person who is if you have a team and you have an established team that does trauma-informed care, and they can bring somebody back gently and walk them through bypassing some of the systems. We all like to have our systems, and you go to desk A, B, C, D. And if we can bypass in whatever way works with your situation to allow the person to feel in a smaller situation and a less open situation, they're going to feel safe.
But even in your situation, it's having the staff treating everybody the same and being warm and welcoming to everyone. I mean, because it's a women's clinic, so you could have women from all kinds, walks of life and demographics there. But having, your staff trained to treat everyone the same and think not less of somebody or more of another person. Yeah.
And that comes down to your staff, all of us
exactly
really loving the people for who they are. And I don't know if that's much training as really a heart of compassion. And hopefully all of us who are in healthcare, and again, we would hope that if we're in healthcare, we're in a situation where we are there to serve, that we're doing it because of a heart of compassion. And honestly, if not, you shouldn't be working. You shouldn't be on this call. So,
yeah.
If you're interested, the heart of compassion should be where you're starting from.
Sure. Yeah, a couple other things I thought of when we were doing our clinics in Bangkok, we offered snacks. And, while they were waiting for the exam, waiting to see the doctor, there was usually some music. They had fingernail painting, they had some snacks, and just helping people and they were coming off the street, so they got a chance to sit down and relax and have some snacks or do their nails and just chit chat with the people that they knew and some of the staff, and also offering resources. And I think that's important, whether it's sort of posters on the wall or having, numbers available that they can look at. They know that, this clinic, and it may not be really pertinent to you, and it wasn't pertinent to our clinic in Bangkok. But, if you put up posters that say, hey, if you're in a hard situation, we get this. And it's sort of a signal that's saying, you can talk to us if you're in a rough spot, if your boyfriend's beating you up, or if you're being forced to do something that you don't know, you don't have to. And so that without asking directly, when we talked about asking directly these hard questions, it is a signal that, when we can ask a question saying, has anyone forced you to do something that you don't want to do or touched you inappropriately? And so if they've already been primed by some of the posters it's like, okay, these people seem to kind of get my situation maybe. And so they might be more willing to answer
Yeah.
that question. And that there's, if they need a phone number because of people to help, that you're not giving them something that could be discovered by a trafficker or something, but it might be something that they could enter in their phone right in the waiting room, and they could save it under a different name or something like that. Or there's all kinds of things. And so those are other ways that sort of having the whole environment speak safety,
Yeah.
and not just, in the exam room or having only the doctor understanding these things.
Yeah, actually, that's what we haven't done that yet. We have little handouts, but sometimes people can't take a handout. Sometimes
Exactly.
they can't,
Or they can't read.
a wall, can't read, and phone numbers, and again, having multiple different ways to make again, a lot of it's making yourself available and being as much as possible the person who's open, so that they feel like there's a safe enough space that they can ask.
Yep.
Um,
But I think, on the other hand, sometimes we do want to be careful about, not asking inappropriate questions. But at the same time, when there's red flags, that we do need to follow up with something. And I want to read this. So there was an article, and I can post the reference in the show notes. But this was a quote from one of the women who was being interviewed, a survivor of sex trafficking. And, she said, so the Planned Parenthood visits, this was from America. So the Planned Parenthood visits for periodic checks for STDs, basically, that's sexually transmitted diseases. And when I went in there, one of the questions they would ask was, how many sex partners have you had in the last 30 days? And I would always say, I don't know, maybe 50. And then they didn't make any comment about it at all. And then I'd say, oh yeah, I'm an escort. And they wouldn't say anything about it. And I thought, this is such bullshit. And they just basically handed me, they always handed me condoms. They would literally hand me like hundreds of them. And that was an anonymous quote by someone who was being interviewed about, what would you like to tell doctors about how they can do their job better to help people, as a survivor? How can you help people like in your situation? And I was pretty profound because, I think we can do harm by not asking the questions that we need to ask. And there's this, and not everyone's perfect. I think we need to understand that there's no perfect way, but there's harm both ways. And we need to pick up, we need to ask these questions, like, because you can normalize the questions when they're in there for an STD check. It's a completely normal question, and they can be honest or not be honest. How many sex partners have you had in the last month? Okay, that's a fair question, because then you can normalize it. We always ask everyone of these. But then when they're saying some outrageous number, like, oh, too many to count, like, ding, ding, ding. I think, hello, doctor, nurse practitioner, or whoever you are, please follow up on that.
Please care enough to say something along the lines of, okay, is that by choice?
Yep.
Or
right.
how would you go about that question? Like, what would be your follow-up question for that?
Yeah. And you're like, oh, well, that sounds like but I would say something like, well, you're an escort. And is that something that, are you alone in this enterprise, or is this something that's being forced on you, or you ever forced to do things that you don't want to do? And, follow up on that, because, in the States, an escort could be legit or could not be. But it is something that you need to explore more, because then, it's try to normalize your questions and say, well, wow, that sounds like a lot. Wow, that sounds like, that sounds like more than, you're having, that sounds like quite a lot. Can you tell me more about that? Or is that something that that's concerning to me? Is that concerning to you? That kind of thing. And is that, or what's going on there? And trying to ask open-ended questions, trying not to act surprised, because then, that would not be your curiosity. Would be like, okay, this is really related to your sexual health and your overall well-being, because if you are being forced into being an escort, for example, then that's something that we really need to deal with.
And so that's the difference when I first said not asking when they've already come through an organization
Exactly.
where we all know what's happening versus you're just meeting somebody on the front end of something. And that's, again, part of that is really being aware
Yep.
of who your patient is and where they're coming from. And yeah, lots of different scenarios where our specific discussions have to be quite different depending on the individual patient situation.
Exactly.
Um,
and
and
it's
again,
normal, but it's normal for patients not to be honest. Like you can ask a follow-up question and then they'll dismiss it. But then because for someone, I mean, they've been confronted with something that, wow, like someone actually might know, someone actually might care. And that might be unsettling. And so they may respond with not the whole truth, but then they'll think about it later and they'll say, oh, I mean, how they survive. A lot of people survive by lying. And not, and so, but there'll be a signal. So if you follow up and then they give you a question, they give you an answer that doesn't quite fit. It's like, okay, well, if you ever want to talk more about this in the future, you can always come back. And, or why don't we schedule another exam in a month, not come back when you want to, but actually say, I'd like to see you in a month or two. How about that? Can we work something out? And not saying like, okay, well, you come back to me when you're ready, because that may not be like, be a little bit more proactive about, hey, can we put something on the schedule? I'd like to see you back, and I'd like to see like, or if someone really is sick, then you really would want to see them back. If you're even if you are treating presumptively, right? They've got some symptoms, but refuse the exam. I said, okay, you can refuse the exam, but you've got some symptoms here, and I want to make sure that we've got you covered. Or making, it's don't lie, but also make genuine reasons to convey that you care about them and that you want to see them again, and that you do care about their health and their well-being. And and sometimes you might be even worried that they'll be alive in a couple months, for sure.
Yeah, and you mentioned something else about not presuming, and it is easy to presume that we know what's good or bad for a patient, or what's their choice or not their choice, and it's painful when we make a mistake on those presumptions, and we can again re-traumatize a patient. We had a young who had been raped, and she was pregnant, and she was taken to a clinic where they said, okay, let's get your abortion scheduled. And she said, well, what is that? And they were talking to her, well, you're too young, you can't have a baby, this was an awful situation, terrible. And no, you're too young, you can't make up your own decision. And she kind of ran away, and they got to us, and we had to, a young girl who's been through that can still have some understanding and choice. So we spent several hours with her and had a really hard discussion about pros and cons of pregnancy at that age, and the repercussions of the situation that led to that pregnancy, and all of these things. But she wanted to have an informed choice. She didn't want to be told, this happened to you, you're a victim, therefore I'm going to do this to you to make you better. That wasn't okay.
No, because you're just forcing, she was forced into that initial situation, and then the helpers are enforcing more decisions on this person. And it
was awful, right?
Yes, I mean, we see this over and over again, not just in healthcare, but we see this over and over again. Yeah.
Telling her what's best for her because of her bad situation is re-victimizing her in a different way. And our bitter mentality is not what she needs at that point. She or he needs care, compassion, a listening ear, education, and choices. And an opportunity to say, wait a second, I think I understand something, but me now. So yeah, we've had some learning situations, and I'm always amazed at how sometimes we think that the trauma people has been through surely would have broken them.
Yeah.
And what I found most amazing is how people can be resilient and how they can recover and be restored. And sometimes the way they're resilient and recover is not what we would expect.
Yeah.
And that's a beautiful thing.
Well,
but
yeah.
It's also, we have to give that opportunity. We can't assume we know what their best way of recovery is.
No, I mean, but they may not know, but it's our job to help empower them to know what that way is, and presenting options. And that just goes back to some more points, like don't be a cowboy, don't be a rescuer, don't make promises you can't fulfill, and don't try to do things for this person. You're doing things with this person. You're not gonna rescue someone, the doctors or nurses, we're in the helping profession. And sometimes, over helping is not helping at all. We're actually doing the worst. Yes.
Yeah. We want to come alongside and be available and then share from our expertise when it's wanted. Yeah.
That's right. Because just because you offer the opportunity to get out doesn't mean that they're ready. Or they may have been thinking about it, but you've got to always be open and not be offended or angry that they haven't, identified you as their hero.
Well, and this, we don't know the article, and I think you'll attach this to the bottom. It's the article from I think it's the AMA. It's a really good ethics article. It goes through a lot of scenarios. And
that's a good article.
Know what the safety scenarios are. And sometimes leaving a situation is much more dangerous at that time than staying in it. And if we're not privy to all of the situations, we can do, again, first do no harm. And we have to be humble enough to recognize what we don't know.
That's right. That's right.
But I would really encourage everybody to read through a couple of those articles, specifically the ethics article.
Yeah, that's a good one.
The British Columbia article has a lot of good examples, just clinical examples of something that was culturally relevant, or, I said the wrong thing and I didn't realize it. And go through those and just start thinking through how to be aware and how to think.
Yeah, and I think it's, and just we'll post those, but I think it's important just for people to know that we don't have to have all the answers, and the way that you've been trained to do things isn't necessarily always the right thing. And like you said the last time, the best thing we can do is to keep learning and have a learning attitude, a teachable attitude, and keep learning, because especially if you can open your eyes up to all kinds of I think when I first started, I made a lot of mistakes, right? But always learning and asking forgiveness, sort of, it's like, oh man, I messed up there. But, I think it's important that I didn't make the same mistake twice. And recognizing that. And if we have that learning attitude, I think it's very, very important. So I'm looking through my notes. I think we covered just about everything. No,
there was just one last thought, and it has to do with all our discussions about when you ask questions or don't,
exactly.
when you do a physical exam or not. Our Western mindsets are trained to gold standard medicine.
Yep.
And that's not always appropriate. Gold standard is not always appropriate or necessary, and you need to focus on the person in front of you rather than what the gold standard is.
That's right. Yeah, that's true. And I think a lot of times also, just with the way that I've observed medicine being practiced in a lot of different countries, and that it really does, it's becoming a lot more formulaic, and a lot more based on, the billable checkpoints and things like that, or it's less personable, more directed to electronic medical records or whatever, or just doctors feeling less and less comfortable with the person in front of them, with the human in front of them. They're more comfortable with addressing this person as a puzzle of pathology, rather than a human. And I think that's just not for this topic in particular, but in general. And I think we're missing a lot. And we will certainly miss a lot of people who desperately need us to see them as whole people and as broken people in many different ways.
Yeah.
So, yeah, good. Well, I think that's a wrap for today. Huh?
Yeah. I think we have a couple questions, right?
Yeah, we do. And I think, yeah, we do have. So, how was that? What'd you think? I hope you learned something. I certainly did. I always learn something talking with Dr. Judy, and she has so much to offer. Apologies for the low sound. The internet isn't always so strong coming out of Phnom Penh, and we're going to work on some of the technical issues for microphone and things like that for the future. But anyway, if you have any future questions or something wasn't quite clear and you really want to know, please get in touch. Get in touch with me anyway about anything. Thanks for listening. Thanks for downloading on Podbean or wherever you get your podcasts, or on the YouTube channel. It's all good. Enjoy the day wherever you are, whenever you are, and we'll see you back here next time on The Doctors Are In. Thanks. Ciao.